Hello, everyone, our listeners and watchers online. Welcome to another episode of Scoliosis Dialogues. This is your official SRS podcast. Today, I have the pleasure of interviewing one of our award winners from the Scoliosis Research Society annual meeting. So I'm your host for today. I'm John Vorhies from Stanford, and I'm joined by Alejandro Gomez-Rice from Madrid, who is an orthopedic spine surgeon. And he has presented a paper at SRS this year called Influence of Smoking on Patient-Reported Outcome Measures in Patients Undergoing Surgery for Adult Spinal Deformity, a propensity score matched analysis excluding known tobacco-related complications. And Dr. Gomez-Rice won the Louis A. Goldstein Best Clinical Research E-Point Award. So congratulations very much on your award.
Thank you very much. It's a great honor for me to be in this podcast series today.
Excellent. We're happy to have you. So maybe before we get into the nitty-gritty of your research, you can just introduce yourself a little bit and tell us what your practice is like.
Okay. I'm an orthopedic surgeon, spine surgeon in Madrid, Spain. I obtained my medical degree in Universidad Autónoma of Madrid in 2005, and then did my residency in orthopedic surgeon in orthopedic surgery in Getafe, which is a small hospital in the south of Madrid, but with a good spinal unit. In fact, it's a great place to learn spine surgery because there was a pretty good spinal surgeon there, Enrique Izquierdo, who's my mentor. That's now retired, but he's still an SRS member. I stayed there until 2020, and for the last 3 years, I've been working in Ramón y Cajal, which is one of the biggest hospitals in Madrid. We have a great human team there and the latest state-of-the-art technology, so I'm very happy. I did my PhD last year, investigating about the role of clinical photography in adult spinal deformity. I've been a member of the European Spine Study Group for the last 2 years when Ferran Pellicer invited me to join, and I feel very lucky because it gives me the chance to interact with such privileged minds in the ESSG, and this is my second study with them, and I hope there are many to come. And I think that's it. That's me.
Yeah, no, I hope there's many more to come as well. So tell us a little bit about the study group.
Well, it's the study group. It's a multi-centered European study group, mainly about adult spinal deformity. There have been a couple of new centers introduced last year, so it's 8 hospitals now. So it's we have the annual meeting once a year. It's coming in a couple of weeks now, and we have research meetings every 3 months, and I get to learn a lot from everyone there because it's a lot of different ways of seeing things, and some people are more clinical, some are like biomechanics experts, and it's great for me. I'm just learning there, really.
Mm-hmm. And so it's a prospectively collected database of adult spinal deformity patients. Is that
right? That's it. There's a lead research coordinator in each center getting all the data, the radiographic data and the clinical data, and it's prospective. It's been working since 2010. Yeah.
Mm-hmm. How many centers participate?
How many sites? 8 sites now. It used to be 6 sites now, I think. Yeah.
In which countries, do you know?
Spain, Zurich, Bordeaux. Well, Spain, it's Madrid and Barcelona. Istanbul in Turkey. Ankara used to participate. Now they don't. What am I leaving out? I think that's it. Well, now there's UK also and Strasbourg, that they are the 2 new sites from last year. So Yeah, it's 8 countries, I think.
It must be complicated to manage patient privacy rules and computer systems and languages from all those
Yeah,
different countries.
languages. Of course, there's the thing about languages with the instruments, with the SRS instrument, because they're a bit. Sometimes the translations are not good enough, So there's some items that must be checked in every questionnaire, but we're on it also, yeah. But that's a limitation of all our studies, translation of the questionnaires, yeah.
Yeah. Great. And so, what led you to decide to do a PhD after you were already practicing as an orthopedic surgeon? I'm curious.
It's a good question. I'm not sure if I know the answer because I wanted to improve, I suppose, my research skills. That's the main reason. Yeah. So I couldn't tell you really what's my motivation. I like research, so it
Wanted to get a little
seemed
better
like
at it.
the logical thing to do. I don't think in Spain it's really useful for my clinical practice, but I wanted to have it.
Yeah.
I'm always
Did you
aiming to
continue?
do something else. Yeah.
Did you do it part-time and continue to practice
Yeah.
surgery while you
Yeah,
did
I
the
did it. I did
PhD?
it part time. Yeah, took me 5 years, but I did it part time.
Hmm.
Yeah.
That's great. Um, okay. Well, maybe we can get into your paper a little bit, and perhaps you'd like to just give us a brief summary of what your methods were, your big question, and your findings for our listeners who haven't had a chance to see the whole presentation.
Okay, so usually when you think about tobacco and adult spinal deformity, you think about the complications. You think about worse clinical outcomes, but only because they get more infections, they have more mechanical complications, more pseudos. So what we wanted to know if there's a relationship between smoking and clinical outcomes measured in PROMs, excluding the tobacco-related complications. So that's what we did. We had 692 patients without mechanical complications and without infection. And of those 692, 154 were smokers. So what we did is, after propensity score matching for age, BMI, number of fused levels, and global tilt, we had 153 pairs of patients that were homogeneous regarding baseline parameters and surgical data. And in those 153 pairs of patients, we saw that smokers had worse baseline parameters, and smokers also had worse results measured in PROMs at the end of follow-up at 2 years. We didn't find a statistically significant difference in the improvement after surgery. So the percentage of patients reaching the minimal clinically important difference was similar to both groups, but the percentage of patients reaching the patient acceptable symptom state was significantly lower for smokers. So what we're seeing here is that smokers are in risk of inferior outcome, not only in terms of complications, but also in terms of patient-reported outcomes. So it's really a simple idea. It's just a bit different that it's what's usually been done with smokers.
Can you tell me a little bit more about the definition of what was an acceptable clinical state to the patients?
Well, that's taken from other paper, adult spinal deformity. It's a paper by Ann Mannion. So it's defined with the questionnaire, with the SRS questionnaire. You have like, it's very similar to the MCID, to the very similar methodology to get it, but it's a bit different because it just looks at the state of the patient, not to change his experience with time or with a surgery or with a treatment.
Yeah, so it sounds like that you have identified in smokers a group of patients who started off in a worse position, and they did improve by a similar magnitude than non-smokers, but they ended up worse than the non-smokers because they started off worse than the non-smokers.
Yeah, that's it, and that's previously been seen in other in other orthopedic pathologies like in meniscal tears or shoulder arthroscopy. It's not a new thing. It's not a new thing in general. It is a new thing in spine surgery, but you can see that, and there are multiple possible explanations for this. What we've seen is not just an issue of pain, because we know that spinal pain is correlated with smoking. That's been proven previously in multiple studies. But it's not just an issue of pain. It's rather more an issue of global spectrum of negative impact. No, I think.
Mm-hmm. So one of the questions I had looking at your data, obviously it's represented across a number of different centers, and I know from my experience, I'm a pediatric deformity surgeon, so most of my patients don't smoke, thankfully. But my adult colleagues have variable criteria for when for how they will counsel a patient who's a smoker for doing an operation, and some of them are more strict than others and might demand that a patient quit smoking or reduce smoking before they'll even be considered for an operation of this magnitude. Can you speak to how criteria might vary for offering surgical intervention to patients who are smokers across these institutions?
Yeah, that's a tricky thing. You're completely right. Each surgeon has a different way of telling the patient to stop smoking. I know we all do it, but in a different ways. The tricky thing really with this was what to do with the former smokers, because lots of our patients or former smokers were recently quitters, because some of them quit to get to surgery. So there was lots of group crossing during follow-up between ex-smokers to smokers again, and we didn't want to include. Well, our statistician advised us not to include those patients because of that, and because smoking status was self-reported. So we didn't take measures of blood samples. We asked the patient if he was smoking. So former smokers, it could be a misreporting due to I don't know how to put this. Patient sometimes socially doesn't want to tell you that he's back on smoke. You know what I mean? And that's a bias that could be introduced using the former smoker sample. So we didn't do any analysis on them. So,
what proportion of patients do you think were former smokers who then relapsed? Is that a very small number, or is that a significant number?
It was a significant number. Maybe we had, I don't have the numbers now because we excluded those patients, but maybe we had like 200 former smokers and 30 of those group crossed during the follow-up. So that's quite a big number, but so we couldn't get any significant conclusion for them. And that's a question that remains unanswered in our study. What effect smoking cessation has on PROMs? How long does it take to get the same results? And if it's a matter of the personality of the smoker or just the nicotine he's getting into his body,
Yeah, you wonder whenever we have a prognostic study like this, if if smoking is a modifiable risk factor, or if once you've been classified as a smoker, you're always going to be in that category of having worse PROMs. What do you think?
Yeah, that's the thing. I'm not sure, really. I'm not sure. I can't answer that with this data. So I think to some degree it's a modifiable factor. I'm sure for complications it is. I'm not sure if it's a modifiable factor for PROMs, really. I can't answer with my data then.
Yeah. And then, so you excluded patients with mechanical complications in pseudoarthrosis, partially to sort of make this a cleaner study, right? Just to look at the independent effect of smoking on patient-reported outcome measures, excluding complications. So, you excluded complications in the smoker and non-smoker group. Is that right?
Yeah. Mechanical complications were excluded. Not We excluded infection and mechanical complications. We didn't exclude any other type of complications, just mechanical and infection.
Yeah. And how many patients were excluded because of that? Do you know?
Roughly 400 or so. That was before the propensity score matching. We have lots of mechanical complications. Because we have a long follow-up. So
yeah,
lots of mechanical complications.
Yeah. So it sounds like you could use this paper to help counsel your patients that in the best of scenarios, you're still not going to quite achieve the health status of someone who was never a smoker, but you still have a lot to gain from adult spinal deformity surgery. Is that fair to say?
If everything goes well, yeah. You
in
can
in the best case scenario.
That's it. If everything goes well, you can improve as much as a non-smoker, but you still are in risk of inferior outcome. That's the thing. And that's true regardless the type of treatment the patient gets, because even if you're not operating on this patient, they have worse baseline problems. So even if they're not getting surgery, they should stop smoking. That's roughly what you should say them. Yeah.
Well, yet another health benefit that we can ascribe to quitting smoking.
Yeah. Yeah, that's the thing, really. Yeah. Something else we could put into the package of, the cigarettes. Yeah.
Great. All right. Well, any other ways that you think this is going to change the way you practice, or how should our members interpret these results in their practices?
Well, I'm usually, but I'm very assertive with my patients about quitting smoking, because I'm always thinking about complications, but I think there's something else. There's something more than the complications. We know that tobacco accelerates disc degeneration. We know it messes with the autonomic nervous system. So there's a sympathetic predominance in smokers. So there are lots of things that tell us that a smoker is not going to do as well as a non-smoker with every treatment we give them. So it's just something else to tell them. Even if you don't have a complication, expect to not be as fine as your colleague who doesn't smoke is. That's the message.
Great. All right, loud and clear. Don't start smoking, and if you are,
that's it.
You should probably
Stop
quit.
It. Yeah.
Great. All right. Well, thanks very much for joining us. Congratulations on your award, and thanks to our listeners for joining us for another episode of Scoliosis Dialogues. And stay tuned. There's plenty more to come.
Okay. Thank you very much. Thank you for having me here.
The Scoliosis Research Society is a nonprofit professional organization made up of physicians and allied health personnel. Their primary focus is on providing continuing medical education for healthcare professionals and on funding and supporting research in spinal deformities. Please visit srs.org for further information.